Well, ladies and gentlemen, thank you very much for all being here this evening. It is lovely to have an audience so timely and ready and eager, and so many of you filling the room this evening. I know it's quite late in the day, in the middle of the week, but I think that reflects the importance of today's event, which is co-hosted by MEP Stelios Kimbouropoulos and the EFPIA, and supported by the other partners as well. Now, a little bit of housekeeping. My name's Jennifer Baker. I'm going to be your moderator this evening, trying to steer you through the various panels. We've a lot to get through, a lot of great speakers. I should warn everyone, there is interpretation. You will find the headphones. The channels are 7 if you want to hear in Greek and 2 if you want to hear in English, and we will swap between the two today. We're calling today's event Time to Act, Building a Pharmaceutical Framework Fit for Rare Diseases. I'm sure many of you know it is Rare Diseases Week. And within the context of the pharmaceutical legislation package, we know exactly how timely it is, especially if you're in Brussels. I'm going to hand the floor over now to Stelios to give us a warm welcome and tell us the importance of today.
Yes, thank you very much, dear Baker, and thank you all for being here, dear speakers, dear participants. First of all, I would like to thank EFPIA, European Federation of Pharmaceutical Entrepreneurship, and SMA Europe, the Greek Association of Patients, the initiative, Screen for Initiative, for your support, and in a very important, huge dialogue, a multi-level dialogue for the upcoming revision of pharmaceutical legislation, and not only for that, and to a special focus on orphan drugs and rare diseases. I'm going to translate to go into Greek. Από την περίοδο πριν εκλεγώ Ευρωβουλευτής, ως ενεργό μέλος μέσω της κοινωνίας των πολιτών, προσπαθούσα να αναδείξω τα θέματα υγείας των ασθενών με σπάνιες παθήσεις, γενικά το κομμάτι της αναπηρίας και τι σημαίνει αυτό, αλλά και πώς ακόμα και μετά την θεραπεία οι άνθρωποι με σπάνιες παθήσεις θα μπορούν να ζουν με ανεξάρτητα, να ζουν την ανεξάρτητη διαβίωση. Τώρα, μετά από κάποια χρόνια με άλλη ιδιότητα πλέον, αυτή του Ευρωβουλευτή, είμαι πραγματικά χαρούμενος που διοργανώνω μία εκδήλωση σαν αυτή και βλέπω φορείς ασθενών, εκπροσώπους της ιατρικής κοινότητας, εκπροσώπους των φαρμακοβιομηχανιών, εκπροσώπους της Ευρωπαϊκής Επιτροπής και συναδέλφους ευρωβουλευτές σε μία αίθουσα ενωμένη, έτοιμοι να συζητήσουμε για το πλαίσιο της αναμενόμενης αναθεώρησης της φαρμακευτικής νομοθεσίας, που θα ανήκει σε μία ευρύτερη ευρωπαϊκή πολιτική για την υγεία, μία κατάσταση, μία συνθήκη που την αναζητούμε όλοι και θέλουμε να τη δούμε να συμβαίνει. Είναι αλήθεια ότι η πανδημία έφερε στην επιφάνεια μία σειρά από δομικά προβλήματα και αδυναμίες της Ένωσης, όπως την έλλειψη συντονισμού μεταξύ κρατών μελών, αλλά ταυτόχρονα και προκλήσεις που σχετίζονται με την ανθεκτικότητα των αλυσίδων παραγωγής, δεδομένης πολυπλοκότητας της παραγωγής φαρμάκων και εμβολίων και την ενίσχυση της ανταγωνιστικής θέσης της Ευρώπης στον γενικότερο και διευρυμένο ιατροφαρμακευτικό κλάδο. Αυτή ήταν και η αφορμή για να ξεκινήσει η συζήτηση για μια πιο συντονισμένη και στιβαρή ευρωπαϊκή πολιτική για την υγεία, αλλά και την ανάγκη μετά από 20 χρόνια να επαναπροσδιορίσουμε το φαρμακευτικό πλαίσιο. Τα τελευταία χρόνια έγιναν μια σειρά από σημαντικά, ίσως πρωτοφανή θα έλεγα, βήματα προς αυτή την κατεύθυνση, με τη βελτίωση του συντονισμού μεταξύ κρατών μελών, την ενίσχυση του ρόλου των υπαρχουσών υπηρεσιών, όπως είναι ο Ευρωπαϊκός Οργανισμός Φαρμάκων, το Ευρωπαϊκό Κέντρο Πρόληψης Ελέγχου Νόσων, αλλά και κάτι που δημιουργήθηκε από το μηδέν, η αρχή ετοιμότητας και αντιμετώπιση καταστάσεων έκτακτης υγειονομικής ανάγκης, η λεγόμενη χείρα. Θεωρώ όμως ότι δεν υπάρχουν αυτά. Η νέα πρόταση της Ευρωπαϊκής Επιτροπής για την αναθεώρηση της φαρμακευτικής νομοθεσίας και συγκεκριμένα για τα ορφανά φάρμακα πρέπει να εξασφαλίζει την ίση πρόσβαση των ασθενών σε θεραπείες και τη στήριξη της καινοτομίας στον κλάδο, αλλά και την ενίσχυση της παραγωγικής διαδικασίας εντός της Ευρωπαϊκής Ένωσης. Η Ευρώπη μπορεί και πρέπει να παίξει πρωταγωνιστικό ρόλο στην παρασκευή νέων φαρμάκων και να εξασφαλίσει μέσω και των κλινικών μελετών εντός και την άμεση πρόσβαση των ασθενών σε νέα φάρμακα. Φανταστείτε ότι μεταξύ του 1973 και του 1983 υπήρχαν λιγότερες από 10 θεραπείες για τις σπάνιες ασθένειες. Από το 1983, μέσω ειδικών εθνικών χρηματοδοτήσεων και της υπάρχουσας Ευρωπαϊκής Φαρμακευτικής Νομοθεσίας, έχουν βοηθηθεί εταιρείες για την ανάπτυξη και την κυκλοφορία στην αγορά περισσότερων από 400 φαρμάκων και βιολογικών παραγόντων για σπάνιες ασθένειες, και αυτά στο πλαίσιο της Ευρωπαϊκής Ένωσης. Παρ' όλα αυτά, το πρόβλημα εξακολουθεί και παραμένει σημαντικό, αφού το 95% των σπάνιων παθήσεων συνεχίζει να μην έχει μία διαθέσιμη θεραπεία. Είναι όμως τόσο σπάνιες οι ασθένειες όσο συνηθίζουμε να λέμε? Στην Ευρωπαϊκή Ένωση με τον όρο σπάνια εννοούμε κάθε πάθηση που προσβάλλει λιγότερο από 1 στους 2.000 ανθρώπους. Μάλιστα, οι περισσότεροι ασθενείς πάσχουν από ακόμη πιο σπάνιες ασθένειες που επηρεάζουν ένα άτομο στα 10.000 ή και περισσότερους ανθρώπους. Περίπου 5.000 με 8.000 διακριτές σπάνιες ασθένειες επηρεάζουν το 6 με 8% του πληθυσμού της Ευρωπαϊκής Ένωσης. Δηλαδή μεταξύ 27 και 36 εκατομμύριων ανθρώπων. Μιλάμε για ένα μεγάλο αριθμό ανθρώπων. Αν λοιπόν μεταφορικά όλοι αυτοί οι άνθρωποι ήταν συγκεντρωμένοι σε μία χώρα, θα δημιουργούσαν την τρίτη μεγαλύτερη χώρα του κόσμου. Επομένως, θα ήθελα σήμερα όλοι οι ομιλητές και οι συμμετέχοντες να έχουν στο μυαλό τους ότι δεν μιλάμε για κάτι τόσο σπάνιο, αλλά για πολλούς ανθρώπους που μπορούμε μέσα από την πολιτική που θα υιοθετηθεί μελλοντικά να αλλάξουμε πραγματικά τις ζωές τους και να εξασφαλίσουμε μια καλύτερη ποιότητα ζωής. Από τα βάθη της καρδιάς μου σας ευχαριστώ όλους που καταφέρατε και ήρθατε εδώ πέρα σε ένα τόσο σημαντικό και θα έλεγα χρονικά αξιόλογο γεγονός για όλα αυτά που έρχονται στο μέλλον. Σας ευχαριστώ και πάλι.
Thank you, Stelios. Some quite stark figures that you're highlighting for us when you really drill down into them. I'm going to hand over, as you mentioned as well, there are many other sponsors today, but we have an FPI representative, Olympias Papadimitriou, President of the SFEE and also General Manager of Novo Nordisk. Olympias, let me hand over the floor to you to say your opening remarks.
Thank you very much. Ladies and gentlemen, distinguished guests, good afternoon. Dear Parliament Member Kimbouropoulos, thank you very much for organizing this event and also for the invitation and the opportunity to take part into this, because this definitely is a unique opportunity to discuss all together and examine how the European Union pharmaceutical strategy can shape European healthcare and innovation. The revision of the European Union pharma legislation definitely represents once-in-a-generation opportunity to ensure that we have a modern approach that matches our ambition to be a hub of medical innovation. And this is our opportunity to ensure that Europe stays innovative and competitive by maintaining a robust and predictable intellectual property framework. When it comes to rare diseases and pediatric indications, the EU orphan medicine and pediatric regulations have transformed the landscape in areas of significant unmet need in Europe. Although there is much room for further innovation, the success of these legislations should be explored as they provide invaluable insights into what really works in driving the science behind unmet need. As you mentioned, Mr. Kimbouropoulos, several years ago, the EU regulation on orphan medicinal products, when this regulation was introduced, there were only a few treatments that were approved for more than 6,000 known rare diseases. And today, 22 years later, after the entry into force of the OMP regulation, there are more than 200 new orphan medicines available, addressing the needs of at least 6.3 million rare disease patients. Indeed, this success has revealed deep inequalities across the European Union. Approval of new therapies does not necessarily result in access for patients. Root causes, though, of unavailability and delay to innovative medicines can be found in the medicines access systems and processes in the EU member states and the corresponding impact on commercial decision-making. During the European Health Summit last December, FPA launched its Rare Disease Moonshot, a new initiative to boost research and development into rare diseases and pediatric indications. The Rare Disease Moonshot represents the commitment and collaboration of 7 organizations to break the barriers and find new treatments for diseases and conditions that still have no therapeutic option. It also represents a response to the European Commission's call to address unmet medical needs. Dear colleagues, undoubtedly Europe needs a solid pro-innovation ecosystem supported by a stable intellectual property framework and a world-class regulatory system. It's time to rethink what kind of European pharma industry we want and we need. And it's also time to consider what really drives the discovery and development of new treatments in key areas such as rare diseases and pediatric indications. Allow me to say that especially for rare diseases, to facilitate the conduct of clinical trials, to collect and leverage the right evidence, to incentivize R&D investments, to reduce the delays in diagnostics, to provide integrated patient pathways, and also to establish a common framework for HTA assessment are definitely directions that the new European legislation for pharmaceutical policy should support. Thank you very much, and our strong belief is now it's definitely the time to act.
Thank you, Olympias. Let me turn now, Peter Liese, also a member of the European People's Party. Give us your perspective. You've obviously taken a busy schedule and squeezed in today to see us. Why has it been so important for you to do that?
Yeah, thank you very much, and a big thank you to Stelios and all those that helped to organize this conference, including FPA. The topic is really close to my heart. I did my medical thesis in the Institute for Human Genetics in the University of Bonn, and many of those diseases that I dealt with are rare diseases. So, and also I met parents, I met patients. Then I worked in the pediatric department of an hospital, and also here I met small patients with rare diseases. That's why I know how big the challenge is, and I also am the patron of one of the associations in my country, Germany, the Morbus Gaucher Association for Germany. So that's why I really wanted to be here. Unfortunately, I have another meeting at 6:30, but it was no option for me to just not speak to you. But I decided to be here for half an hour is better than nothing. And, it is clearly a European issue. You know, people are always arguing Europe is dealing with things that should be better placed at regional or national level. The treatment of rare diseases is a European issue because either we do it at European level or it won't work. It is just impossible for national systems, the research, the clinical trials. Also, a proper treatment is only possible if we cooperate. And that's why there is no, yes, there is a question of subsidiarity. But subsidiarity means, of course, things that can be better dealt with at a lower level should be dealt with at a lower level. But the other side of subsidiarity, many of the anti-Europeans always forget, when a thing can't be solved at the lower level, it needs to go to the higher level. So subsidiarity imposes this topic to Europe. And that's why we need to work, and that's why it's good that we have this framework, this existing framework for orphan drugs. And it's important to look at it and improve it. And that's why I agree that the Commission is working on it. It's a good idea. We have seen the leak from last week. It was maybe the most wanted document in the medical area all over Europe. And I just spoke to Georgios. It's good that it's a leak and not the final text, because there are some good ideas in it, but it can still be improved. So I like, personally, the concept of unmet medical needs. So we did it in our initiative report on the pharma strategy. We did it also in the report of the Special Committee on Cancer, that we want to promote real innovation. So we don't need the 27 beta blocker. The Me Too is not what we want. We want to really address patients' needs. We want to promote real innovation, and that's especially important for rare diseases. But we shouldn't do this by reducing the protection of intellectual property, reducing the incentives for innovation, but rather put an add-on. And that's how we should maybe look at this proposal and improve it. So, because it's not always so easy. When you start the process of developing a new drug, you don't know if it is successful and how much it's better than the existing therapy. This is the purpose of a clinical trial, that you find it out. And maybe it's a little bit better, maybe it's much better. And when you have a too restricted framework, that may block the innovation that we definitely need. So I think we need to look at this, discuss it in depth, and find the best possible solution. So, because my time is short, and I also want to listen to Georgios, I stop here, but not without giving a special credit to Stelios. Stelios is our coordinator in the Special Committee on COVID. He's a very active member of the working group of the EPP on environment and health. I would say he's really one of the heroes in health policy in the European Parliament. Stelios, thank you for all your work.
And thank you, Peter, for raising the subject of subsidiarity already in our discussion today. I think we'll come back to that in one or two of the panels. Georgios Vasides, let me hand over to you to give us your opening thoughts. You're going to tell us a little bit about the review of the pharma framework, key objectives for rare diseases. You're head of cabinet for Commissioner Stella Kyriakides within the European Commission, of course. So thank you very much for being here.
Thank you very much, Jennifer, dear Mr. Kiburopoulos, dear Mr. Lise, ladies and gentlemen, dear friends. It's a great pleasure for me to represent Commissioner Kyriakides in this very important event, and a very timely event it is for all the reasons that you heard, and certainly for the, let's say, the central importance of dealing with rare diseases in this reform of our pharma legislation, a reform which is a very integral part of our work to build a European health union, work which, let's say, also comprises some of the very important initiatives you heard that came in the wake of the pandemic, the work to reinforce the ECDC, the work to reinforce the EMA, the work to set up HERA, and certainly to to change the way that we do health policy in the European Union, also comprising, of course, all the work that we have done to set up and propose and, of course, establish a European health data space. So it comes under this transformational agenda that we see, of course, accelerated by the pandemic, but also driven, let's say, by a vision from President von der Leyen and by Commissioner Kyriakides to connect the dots much better and to deliver better outcomes for patients for a healthier, let's say, and much more resilient Europe in the area of health. So I want to thank Mr. Kiburopoulos for bringing us all together here to discuss this topic. Now, I will agree fully with Mr. Papadimitriou that here we have essentially a once-in-a-generation opportunity to get this right when it comes to reforming our pharmaceutical legislation. And I have to tell you that from the very outset, the vision of Commissioner Kyriakides and, let's say, the marching orders that she gave us to deliver this reform right from the time that we were developing the pharmaceutical strategy is that we have two objectives which are at equal, let's say, level of priority. The first, to make sure that all patients in Europe have access to affordable medicines. And the second, but equally important, to ensure that Europe remains a friendly place for the pharmaceuticals business and to ensure that our industry remains both innovative and also globally competitive. Now, of course, getting this balance right will never be an easy task, and for us it will be the most significant challenge of the weeks to come until we get to the adoption of the proposal, we hope, sometime in March. Now, to achieve this and to get this balance right, we need to have strong incentives which support innovation and the competitiveness of our pharma industry, including in the areas of unmet medical needs and certainly also in the area of antimicrobial resistance. And that's why we think that these incentives should reward positive behavior and a positive, of course, contribution to the social issues that we are discussing here today, including, of course, access to medicines. Now, whether this means developing new medicines for unmet needs or launching a new medicine in all member states so that medicines and innovation can reach patients regardless of whether they live in the EU or from what disease they suffer. Now, so for us, this is a key theme that runs throughout this reform. The second key topic, which we see a clear need to address, is security of supply. With the pandemic and, of course, with the recent supply shortages as the backdrop of the work that we're doing now, we see a clear need to act. Now, the reform also aims to make medicines greener, to reduce administrative burden for industry, and to streamline regulatory procedures through digitalization to reduce time and costs. These are all lessons that were learned during the pandemic through the acceleration and the simplification of procedures, which we saw what they can deliver. Now, on rare diseases specifically, improving access in areas with no treatment, for example, for rare and pediatric cancers, is at the heart of this reform. As you heard, there are up to 36 million citizens in the EU affected by one of more than 6,000 rare diseases currently recognized. Now, these diseases can be life-threatening or they can be chronically debilitating. We are truly delighted that today we have this opportunity to shine the light on the importance of ensuring access to orphan medicines from the patient's perspective. You also heard that before the orphan regulation was adopted in the year 2000, companies had limited interest in developing medicines for rare diseases. There was a clear market failure, which had a huge impact on patients and their families. Now, over the last 20 years, our rules provided a conducive environment, encouraging the development of medicines for patients with rare diseases, and also, of course, safeguarding safety, quality, and efficacy. Since 2000, over 200 orphan medicinal products have been authorized. We supported research on rare diseases through our framework programs. From 2007 until the year 2020, almost 3 billion euros have been attributed to over 400 research projects. But we know that we are not yet where we want to be. The facts are, as you heard from previous speakers, that 95% of rare diseases still have no treatment. The affordability is also a big question, including, let's say, the issue of rare diseases, but also extending to other medicines, and it remains a persisting challenge for EU healthcare systems. Access, once again, differs greatly. It's extremely uneven from one member state to another. So there is work for us to do here, and clearly there are rules that we can adopt to improve the outcomes. And that is why, with this reform, we intend to address these shortcomings in the rules by using a variety of tools, including modulated and tailor-made incentives. Now, we consider that we need to depart from a one-size-fits-all system of incentives towards a more balanced framework that caters for, first, the development and authorization of orphan medicines that address the needs of patients, including especially children. Second, to ensure timely access to treatments for all patients. And third, to give pre-marketing incentives like early engagement and support from the European Medicines Agency, as well as accelerated assessments for possible orphan products. And this, of course, to arrive at a system that rewards innovation while facilitating competition and a contribution to the affordability and to the long-term sustainability of health systems. Now, here we should be clear that while we aim to boost the development of medicines for rare diseases where no treatments currently exist, we will continue to incentivize the development of therapies for all rare diseases. We are also very aware that there is an interest, a broad interest out there, and we hear this from many circles, in integrating a possibility for joint procurement of orphan medicines in our future rules. And I can tell you that as we learned during the pandemic, and certainly as we saw in the last few months with the shortages of supply, that this should remain on our radar screen as a potential, let's say, option for the next steps. Now, dear Mr. Kiburόπουλος, dear Jennifer, patients suffering from rare diseases have been and they remain at the heart of what we do here, and certainly a key priority for my commissioner. Patient experiences with rare diseases, we think, really exemplify the reason we have to act in this context and to put forward a pharmaceuticals reform which is balanced and delivers both for the patients and for the industry that needs to deliver the innovation for them. So that's why our ambition is to put forward a future-proof legal framework that delivers both for patients and for industry, and one that enables the development and the timely authorization of medicines which do address unmet medical needs. One in which patients can access the medicines they need, and one which guarantees that Europe will remain competitive and a leader in research and innovation. Now, we know that these are ambitious and important goals, but we are quite confident that we can reach them if we all work together in this endeavor. Thank you very much.
Well, thank you very much, gentlemen, for setting out the scene for us, setting the groundwork with your opening remarks. Stelios, you're going to stay with us for the first panel, but gentlemen, you're free to go. And I would like to invite up our speakers who are going to join us for panel one, discussing living with rare diseases, the patient's perspective. We have joining us Arabella Akaline, who is president of the European Alliance of Neuromuscular Disorders Associations, and Jan Lokam, CEO of Euridis. So, gentlemen, and Arabella, please do join us. So thank you very much indeed. Now, I'm going to, because Stelios, we've already started with you, and you will be staying with us and joining us for our final remarks as well, as host of today's event. But this panel, we're going to look more at the patient perspective, the overall quality of life question. I'm sure we'll touch on the policy initiatives, but just to give people a guide for what's coming up after this panel, we will then be going to have a second panel looking at the value of newborn screening, and last but not least, then coming back to the revision of the pharmaceutical framework. So
I was looking for a higher.
It's absolutely no
so
problem.
I can see you.
Okay, Arabella, let me turn to you and ask you to give us an overview of the view from your associations that you're representing, why now is timely, but the patient's perspective, if you like, on a day-to-day basis. You can press that button. Press the red button.
Okay, this one. Okay. So, hello everyone. First of all, I would like to say a few words about myself, because I think this is the proper way to start, and sorry for being nervous because it's my first time here. And yes, I'm lucky enough to have a great professional by my side, so I get even more nervous. So I am Arabella Akaline. I am a patient with a rare disease myself. I have Charcot-Marie-Tooth disease, which is actually the most common neuropathy, a neuromuscular condition. In 2000, I didn't have a lot of expertise in Romania, in my country, about my disease, so I turned over to Google, of course, and found CMT Association in Canada and in America, and I got all my information from there. In 2019, I started my Romanian association for patients with CMT and with other neuromuscular conditions and joined European CMT Federation. I'm actually their board member and their Eastern Europe ambassador. And in November 2021, I was more than blessed to be elected president of EAMDA, which is European Alliance of Neuromuscular Disorders Associations. So I got engaged with a lot of patients from different neuromuscular diseases. As you all know, most of them are rare diseases. And coming back to your question, I think I already missed the... Yeah, you wanted me to speak about my experience, right?
Well, exactly. And
Okay.
we mentioned, Peter, in his opening remarks, we mentioned that this is a European issue, that it
Yes.
shouldn't be piecemeal broken down into different member states
Yes.
in some ways that some bits of legislation are. You know, you're representing an alliance, a European alliance. Tell us about why that's important as well.
Well, most of all because we all face common issues when we speak about neuromuscular conditions. Unfortunately, there are the same problems all over the world. The difference is the fact that some countries manage to address them and to find solutions for the patients better than other countries. And we found out that the proper way to do it is not to try to solve the problem in each country, but rather create alliances and try to join forces and become a stronger European voice so we can disseminate a message at a European and even international level at one point. And this try to change things from big to small, I mean from European level to national level. Yes.
Jan, let me turn to you. You're representing non-governmental, patient-driven organisations. So tell me a bit from the patient's perspective. What does it mean day to day, and how do they feel the legislative process? Is it so remote that it feels out of touch, or obviously for people like yourselves on the panel, you're very much involved in it day to day?
There's really two questions in your question, but starting maybe from the patient perspective of living with a rare disease, I'd like to refer to a survey that we did some time ago called the Rare Barometer, and there is 3,000 families who answered across Europe in 23 languages. And what they've been declaring is that for 52% of them, so 1 in 2, it's a severe or very severe impact, the very severe being 20%. But then when you think about daily life, how does it translate? The time burden, for instance, it's for 2/3 of them, more than 2 hours of daily task linked to the disease for the carers. And that burden falls particularly on the women, who are more often the carers. And because that's not enough, it also means for the patients themselves that for 8 in 10 of them, they have difficulties to accomplish some of the daily task. And last, that for 7 in 10 patients or carers, they had to reduce or stop their professional activities because it was not compatible anymore, which means also additional financial hardship on the family. So that's what it means. And then we have also, obviously, more information about inclusion at school or at work. But the consequences are many. And it also probably changed the course of our life. Adela will not be here and will not be here as a parent if we were not affected by rare disease also. So there is also that kind of consequences. But on the overall collective, the impact is absolutely huge. And that's why we calling to an attention which is not only medical on rare diseases. We're calling really for an approach which is a holistic approach, 360-degree view from the newborn to the adulthood, and in a lifelong approach. And that maybe that's more new because we tend to bring solutions for the newborns, for the infant, for the children, for the adolescent, for the adults. And then there is aging for some of us, like with hemophilia or the diseases. So the lifelong approach, holistic approach, integrating more medical and social care at the local level, national level, but also within a European strategy, this is how also we can change the perspective of life, the strategy of life, the journey of the person, and the inclusion in society.
Stelios, Jan is raising a couple of interesting points there, particularly about the fact that Arabella's here on this panel. You have a dual perspective as someone who is a policymaker and is living with a rare disease. Is there a sense of frustration that drives you to do the work you do? I mean, I presume there is, but I don't want to put words in your mouth. Tell me a little bit about what you find in your position working within the health sector and within the health sector, if you like, of the European Parliament, the health committees and so on.
Yes, I will try to give the image of how I have lived, how is our living experience of someone who has a rare disease, but also have the opportunity to live in a society in which doesn't know what rare disease is. And I will tell my story, and this is why I decided to tell you my story, to give you my experience from a point of view, from someone who is not only a politician, not only a rare disease patient, but also a medical doctor who can understand the different perspective of these three different aspects. And I will continue in Greek. Ήταν το 1985 όταν γεννήθηκα. Και το λέω αυτό για να πω ότι έχει γίνει πολλή έρευνα, αλλά η κοινωνία μας ακόμα δεν είναι έτοιμη. Γεννήθηκα λοιπόν το 1985 και μετά από 2 χρόνια απλά ανακοινώσανε στη μητέρα μου ότι το δεύτερο παιδί δεν είναι το ίδιο με τα υπόλοιπα παιδιά. Ότι κάτι έχει, γιατί δεν μπορούσε να σταθεί, δεν μπορούσε να λειτουργήσει με τον ίδιο τρόπο όπως λειτουργούσαν τα υπόλοιπα παιδιά. Οπότε φανταστείτε μια νέα γυναίκα, ένα νέο άντρα, ένα νέο ζευγάρι λοιπόν, τους γονείς μου, από το πουθενά να τους πούνε ότι το παιδί τους δεν είναι καλά. Ότι το παιδί τους μπορεί να πεθάνει στην εφηβεία και ότι το παιδί τους δεν θα μπορέσει να κάνει τα πρώτα βήματα, να μπουσουλήσει, να χαρεί, να τρέξει, να παίξει με τον ίδιο τρόπο όπως γίνονται με όλα τα παιδιά. Αυτό που μου έχει περιγράψει η μητέρα μου είναι ότι άνοιξε η γη κάτω από τα πόδια της να την καταπιεί. Δεν υπήρχε γνώση, δεν υπήρχε πληροφόρηση και ένας άγνωστος δρόμος άνοιγε μπροστά της. Και για τον πατέρα μου και για τη μητέρα μου, αλλά και για τον μεγαλύτερο αδελφό μου. Αυτό που είχαμε ως γνώση ήταν μόνο το ιατρικό κομμάτι. Είχα την τύχη όμως να έχω 2 υπέροχους γονείς, 2 υπέροχους ανθρώπους οι οποίοι πίστεψαν στο παιδί τους, πίστεψαν σε αυτόν που γεννήσανε. Πίστεψαν στο τέκνο αυτό ότι είναι το παιδί τους. Το πρόβλημα το μεταφέρουμε λίγο στο σήμερα. Η πληροφορία έχει μεγαλώσει, αλλά ακόμα όλη αυτή η γνώση, η πληροφόρηση δεν έχει γίνει ενιαία έτσι ώστε από την ώρα που θα γίνει η πρώτη διάγνωση να είναι δίπλα όλο το σύστημα και να υποστηρίζει την ανάγκη αυτού του ατόμου, την εξατομικευμένη ανάγκη. Αυτό λοιπόν που λείπει και θεωρώ ότι είναι πολύ σημαντικό και πρέπει να συζητάμε μαζί με την οποιαδήποτε εύκολη πρόσβαση στα φάρμακα, την πρόσβαση για όλους στα φάρμακα, πρέπει να συζητάμε και την επόμενη μέρα πώς αυτός ο άνθρωπος, ο άνθρωπος θα μπορέσει να λειτουργήσει μέσα σε μια κοινωνία η οποία δέχεται την αδιαφορετικότητα και πώς αυτοί οι γονείς οι οποίοι ζουν στο άγνωστο θα παίρνουν εύκολα, έγκαιρα και γρήγορα την πληροφορία. Ότι το παιδί δεν θα είναι κάποιο άτομο το οποίο δεν θα μπορέσει να ζήσει, αλλά θα μπορέσει να ζήσει με το δικό του τρόπο. Και αυτό είναι το σημαντικό. Θεωρώ και ερχόμενος από την εβδομάδα του Ευρωπαϊκού Λαϊκού Κόμματος ότι ήταν ο σκοπός που θέλαμε όλα αυτά τα θεωρητικά ασύνδετα μεταξύ τους να τα συνδέσουμε και να φτιάξουμε μια υποεπιτροπή υγείας. Αυτός ήταν ο λόγος που ισχυρά διεκδικήσαμε αυτόν τον λόγο ύπαρξης μιας νέας επιτροπής που θα μιλάει αποκλειστικά και μόνο για την υγεία, για να συνδέσει τα πράγματα μεταξύ τους. Εγώ όμως θέλω να σταθώ και να κλείσω αυτή την παρέμβασή μου με κάτι ακόμα. Αν με ρωτήσετε σήμερα, είμαι ένας άνθρωπος που έχω σπάνια ασθένεια, αλλά πάνω απ' όλα είμαι ένας ανάπηρος πολίτης. Και γίνομαι ανάπηρος γιατί βάζει η κοινωνία τα εμπόδια απέναντί μου, γιατί δεν δέχεται ότι μπορώ να λειτουργήσω και με αυτόν τον διαφορετικό δικό μου τρόπο από αυτό που έχετε εσείς τώρα. Να γράψετε με το στυλό σας, να φάτε μόνοι σας, να σηκωθείτε μόνοι σας το πρωί. Εγώ χρειάζομαι κάποιον προσωπικό βοηθό για να μπορέσω να τα εκτελέσω αυτά. Χρειάζομαι μία ράμπα για να ανέβω σε αυτό εδώ το πάνελ. Δεν είναι το πρόβλημα μου δικό μου, είναι το πρόβλημα το ότι δεν σκεφτόμαστε με αυτόν τον διαφορετικό τρόπο. Και γι' αυτό που είπε ο Γιάν, με αυτό το σκεφτικό λοιπόν, πέρσι είχα τη χαρά να είμαι συνεισηγητής εκ μέρους του Ευρωπαϊκού Λαϊκού Κόμματος για την Ευρωπαϊκή Στρατηγική Φροντίδας. Είναι πολύ άδικο όταν γεννιούνται παιδιά με σπάνια νοσήματα, οι γονείς να πρέπει να αφήνουν τη ζωή τους. Είναι άδικο και πρέπει να το φωνάζουμε και πρέπει να διεκδικήσουμε μια καλύτερη, ποιοτικότερη ζωή. Αυτά όμως τα παιδιά θα μεγαλώσουν και θα ζήσουν σε αυτή την κοινωνία που βάζει εμπόδια. Άρα λοιπόν πρέπει να δούμε πως η αναπηρία ίσον όχι το impairment, αλλά ο τρόπος που η κοινωνία έχει φτιαχτεί και έχει βάλει εμπόδια. Πώς λοιπόν η αναπηρία θα είναι κομμάτι της κοινωνίας, πώς θα είναι σεβαστή και πώς θα αναδιαμορφώσουμε εκ του μηδενός την κοινωνία για να σταματήσουμε να υπάρχουν εμπόδια στο σχολείο, εμπόδια στην υγεία, εμπόδια στην εργασία, εμπόδια στις σχέσεις. Άρα λοιπόν για μένα, όταν μιλάμε για σπάνια νοσήματα, μιλάμε για μια ολιστική προσέγγιση και μόνο έτσι μπορούμε να μιλάμε εάν θέλουμε να δούμε, να αλλάζουμε τον τρόπο που η κοινωνία μας σκέφτεται. Σας ευχαριστώ πολύ.
I'm going to pick up on that last comment that Stelios was making about how there shouldn't be barriers for schools, for work, for relationships. And I want to ask you, Arabella and Jana as well, do you see any commonality of barriers that people with rare diseases face, regardless of their condition, their personal situation, that is related to any of those big key areas in life? And if there are those particular barriers at certain points in life, can you maybe outline them for me? Jan, I'll let you go first since the microphone's pointing your direction.
No, if I'm correct, I don't think that there is barriers in daily life. It really depends not only on the disease, but on the expression of the disease for that specific person. And that's why we're calling particularly to the assessment of functionalities for every person affected by rare disease performed in the centers of expertise, so that we will have an overview not only on the medical situation, but also of the impairments, the consequences of the disease to perform certain functions, and then to be able to better connect with the social system to have some benefits or integration in school, for instance, but also to have a better recognition of these impairments in order for society to adapt and compensate them, as Stelios was saying. But what we have across rare diseases is common challenges when it comes to access to information, to access to diagnostic. Most of the rare diseases, not all obviously, are confronted with long delays, outstanding delays, because they could be reduced from the current still 5 years on average. They could be reduced to 6 months or 1 year maximum. They also face the common issue of lack of investment under the normal condition of the market, and this is why there is this regulation on orphan drugs, which is the political choice by society to create an advantage when investing in that area where there is a lack of return on investment, by providing then a reward, which is the market exclusivity. So this is the kind of common issues that we're facing. And today, what we're facing in terms of access of medicines also is that we see that it's worst for people with a rare disease when there is an available therapy than it is for the other disease areas or for society at large.
Arabella, Jan there mentioned slow access to information, and I was trying to bring in this idea about points that might be levers in society, such as schools or workplaces. Do you think there's sufficient access to information for those kinds of points of intersection?
You mean...
Is there enough training given for teachers, for schools? I mean, at a really fundamental level, outside of the healthcare system, is there information, is there acknowledgement, is there support?
It depends. Again, I will say it depends on the country. Let's say country because, so I'm basically, my basic training is that of a teacher myself. And I must admit, in Romania, we do face this problem. When it comes to children with disabilities, there is not enough involvement and not enough awareness, and no, so it's so disregarded, this sector, and we are still facing challenges when it comes even to access in schools. There are still schools in Romania that are not adapted and accessible for children in a wheelchair, let's say. Or when it comes to children with intellectual disabilities, there it's even more complicated. So yes, unfortunately, especially in eastern part of Europe, we can still see this huge discrepancy and limited access to education. And of course, then access to work. It's again a problem. I was lucky enough to work for a couple of years on an Erasmus Plus project as a career vocational counselor for persons with disabilities. So I had a chance to do this exchange of practices among Romania, Portugal, France, and Hungary. And I could see, again, the differences. So when it comes to access to work, for example, we still have to do a lot of advocacy among employers because there are still these differences. So, but yes, of course, I could see even good models. For example, EAMDA is registered in Slovenia. And in Slovenia, I was actually amazed with the fact that even Ljubljana is so accessible. I mean, actually, Ljubljana, I think it was named the second accessible city in Europe or something like this. So it's not only physical accessibility, but also the fact that they have access to education and employment, which is remarkable. So yes, unfortunately, there are these discrepancies, and I think they must be addressed at European level as well.
Thank you very much. Now, we have to rattle through these panels quite quickly due to time constraints today, but I'm going to see if there's any questions at this point for any of our speakers. If you have a question, raise your hand or in the next few minutes and I will give you the floor. Okay, I think we're dealing a lot with personal issues on this panel, and it's sometimes a little bit uncomfortable here in the European Parliament to hear these very personal stories without focusing hard on the legislation.
But these are also the true stories.
Yeah, I agree. That's why we're doing it, I suppose. But let's turn a little bit, Stelios, to the legislation side. What possibly can be done that will really make a difference in patients' lives that you see? We've all seen the leak last week. Tell us what you think could be improved.
I think that Jan told everything that is needed in order to have a good legislation. We hope to see this leakage that we have seen is not the final, let's say, report, because the thing that we need to see on this legislation is to have a real innovation. This is what I think that is missing. And on the other hand, yes, we want to have this kind of innovation in order to have also good medicinal products for all European citizens. So this is what we need to find a balance between innovation and affordability and easy access. This is the main courses that we need to run in order to have a good final European legislation and a good cooperation among EMA, ECDC, but also with national authorization systems, because I think that after these three elements, we go into pricing. And so we need to find also how we are going to go into reimbursement and insurance. This is the main issues that we need to discuss when finally have the text, because at the end of the day, we need to see health people.
I mean, am I right in thinking that you see this mainly as avoiding discriminatory practices?
I don't know if it's discriminatory, but I think that if we don't find the right proportion of each of this element that I described before, I'm afraid that we'll not be able to have everybody this kind of access. And we talk about a unified Europe. It's not possible in my mind to have access, let's say, in Germany and not have access in Romania or in Greece or in Bulgaria. We need to find the same level of accessibility in every member state.
Well, thank you. Jan, let me put a little bit of an awkward, uncomfortable question to you. How do you respond if people say, well, rare diseases, they're rare, we should focus on getting proper healthcare to everyone, which we haven't already delivered? Why shouldn't we go for the low-hanging fruit first? How do you counter that? And I know Stelios went some way towards that with his numbers at the beginning, but give me your response.
First, I don't think we should oppose the needs of the one with cancer to the one with Alzheimer or with a rare disease. We need to do all of that in parallel, because what we want is a better society where people are at the optimum of their well-being. But rare is not a trap. Rare, when you bring the 6,000 rare diseases together, is meaningful. And that has been the story of that movement in the US, in Europe, and in the world now, is that it brings together people who are rare for each of these diseases or locally, but if they come together in a larger geographic pool like Europe or across rare diseases, then we represent 30 million people in Europe. That's what it is. So that's a large population. As Stelios was saying, when you look at the level of the world, the conservative numbers are 300 million people affected. And you don't even see them because they are not diagnosed, most of them. So that's the first level. So rare and rarity here is not a problem. The problem comes more, honestly, if we were not costing anything to the system, nobody would care. They would say, yes, rare is fantastic, we can pay for them. Let's pay them the social services, let's pay them the medicines. So it's about the economy, if there is an issue about rare. It's, at the end, is that life, that miserable life of that lady, of that woman, or of that man, is it worth that price? This is what we're talking about. And this is where I think the root of the ethical issue of our battle is that every life worth it. And we will leave no one behind. That's the basis of our engagement.
Thank you very much. It's a very strong message. Arabella, I'm going to ask you to give a final thought. Is there anything particularly you want to say to policymakers? We're here in the European Parliament. We're at a really key point in the legislative process. What would you like to see, or is there anything you would like policymakers to bear in mind?
Well, first of all, I want to say that if I don't know, some years ago, people were thinking that people with disabilities need empathy and, I don't know, to be understood. Now we are living times when we can actually say that people with disabilities, people with rare diseases need solidarity. So solidarity should be the basis. Like now, for example, we have this earthquake in Turkey, and people are there and are helping. It's the same situation with people with rare disease, for example. And yes, every life matters, exactly like Jan said. And I would just say, because I'm also a mother, every one of us would understand the fact that every life matters if we had, for example, someone we love or a child with a rare disease. I think the politicians should consider this. They never know when they can develop themselves a rare disease or they can have a child with a rare disease. So rare disease is even more close to the society than they consider. Yeah, thank you.
Also, a very final comment is what Jan said before. As medical doctors, we need, I think, a better education on the issue of rare diseases, and to have also the knowledge of what possibilities are. So I think that also is our responsibility, the responsibility of different universities, to show that someone who has rare disease is not a lost case, but is a person who have the opportunity, if he has the right treatment, he can live a very beautiful life.
Thank you. Very well said. And that will wrap up nicely this panel. So a big round of applause to all the first speakers. So, as I mentioned, we move on to panel 2 already. We're flying through it today, but it's the value of newborn screening. This is something we mentioned a little bit earlier on, that perhaps crosses between so many different diseases that can fall under the umbrella. So we're going to swap over our panellists now. If you do want to grab a coffee, now is a good time. Christine, how do I pronounce your surname? Is it Uyad?
Uyad.
Yes, interesting. Okay.
Very well, nice to meet you. Steve, nice to meet you.
Hi, Steve. Hey. Hello, thanks for... You jumped in at the last moment.
I don't remember my best with no prep.
Okay. Okay, so please, if you bring your coffee back to your seats, you can enjoy it while we talk about the value of newborn screening and the SMA case study. I'm joined by some excellent speakers, as always. Marie-Christine Uyad, who is board member of SMA Europe, who will be telling us a lot more about that. Professor Maurizio Scarpa is from METAB ERN. Steve Bridges stepping in at the last moment, thank you, from the Secretariat of Screen for Rare, and Milan Ferguson, who is Consulting Associate at CRA. Thank you all for joining me. Marie-Christine, let me give you the floor first. Tell us about the study and really set out the parameters for this debate for us.
So I am the mom of a young lady now who is SMA for a long time. And I'm involved in patient advocacy till my baby was diagnosed as SMA, so it's very important for me, and first at national level and then at European level. And just a few years ago, I think in 2020, we discovered that if in SMA, if we can diagnose at birth, it will save the life of this baby. So I was involved in the chair of a newborn screening alliance to promote newborn screening in SMA.
Well, thank you. Well, we'll come back then to the case study. Professor Maurizio, let me ask you then, just give us a brief introduction to your clinical perspective, I think.
Well, thank you very much, and thank you also for the kind invitation and for the organization of this meeting. Why we are speaking about newborn screening and what is newborn screening? Newborn screening is indeed the possibility of analyzing for a certain number of disorders the child whenever it is just born, so in the very first 48 hours of life. And newborn screening is actually one of the major achievements that we have in clinic in the last 60 years. It started in 1960 and with a metabolic disorder, which is phenylketonuria, and these children actually were dying totally neurologically impaired just because they were eating something very toxic. And whenever there was the newborn screening, changing the diet made these children going to the university, having a normal life, and having a family. The spinal muscular atrophy is something very similar, let's say. It is not a metabolic disorder, it is a genetic disorder, of course. And now there are therapies which are really changing the life, only if you diagnose the child when the child is born. So there are movements throughout Europe and the world to make this possible. Let's say that in the United States, from 85% to 100% of children are screened for this disorder already. In Europe, the situation is a little bit more scattered. So there are countries like, I made the list because it's not easy to follow them, like Poland, the Netherlands, Belgium, Slovenia, Norway, and Germany, where the newborn are screened for these disorders. There are other countries like UK, Spain, Italy, Austria, Czech Republic, where there are some pilot programs for that. So it's not really. Why this? Because newborn screening is indeed thought as a cost. But in my impression, newborn screening is an investment. And as a matter of fact, especially for SMA, where if you discover the child in the very first month of life and give the right therapy, you have a child which is walking and not walking anymore, is living and not dying. It's something that should be mandatory and spread throughout Europe as a mandatory thing to do. So one thing that we are doing inside Screen for Rare, which is a movement, and I'm happy that we will speak a little bit later, is to create a consortium of people. So the European Reference Networks, I'm one coordinator of a European Reference Network, which is collecting, in my case, 100 hospitals in 27 European countries, centers of excellence working to spread the newborn screening throughout Europe without imposing the country to do it, but giving to the authorities all the issues to choose and to do the best. And also to try to understand why there are some countries screening for 50 disorders like Italy, and others screening 2 like Romania, or 12 like Germany, or 17 like France. Of course, there are some political decisions under that. But I think that newborn screening is now achievable. The technology is there. It is also, especially for the SMA, a technique black or white. And it is really something that should be done at the European level, because it is really changing the life of these children. I think I stop there.
Thank you. Yes, indeed. Steve, let me turn to you. Screen for Rare is obviously right at the nexus of what we're talking about. So perhaps you can build on what Maurizio was saying.
Yeah, absolutely. First of all, to add a bit more information on the Screen for Rare, as Maurizio mentioned, it's sort of been an organically growing group of advocates, experts, patients, patient representatives at EU level. The actual organisation, Screen for Rare, the founder members are IPOPI, so that's a patient group focusing on primary immunodeficiencies at global level. The International Society for Neonatal Screening, ISNS, and the European Society for Immunodeficiencies. And the objective is to work with EU policymakers to ensure that the EU can become a support base for its member states and encourage optimised newborn screening policies in Europe. I think, you know, it's you can see in this room already as well, but it's really quite rare to meet a rare diseases campaigner or stakeholder of any type that doesn't see value in European work. It's quite rare to find someone who says, I'm only going to campaign in my country because that's what matters. And I think that's because there's been a proof of concept that the EU, both through legislation, such as the ones this meeting's on, but also through being a place for people to network, to speak with policymakers, to come to, you know, the events that Eurodis will organise both this week and on Rare Diseases Day. You know, it's really through all that collaboration that the EU's become a world leader on rare diseases policies. And I think the Screen for Rare group would really like to, without forcing any member state, while respecting their right to deliver healthcare in a way that suits their citizens, we think that it could become a repository of expertise, of knowledge, of best practice from countries that have rolled out newborn screening programs more extensively than some of the others, and ultimately to add value for EU citizens with rare diseases. And there's a range of, you know, benefits that can come from that, but to pick one from, you know, Johan Prévost's own sort of domain, with SCID, severe combined immunodeficiency, actually opens the door to a curative policy, a curative treatment rather. And, you know, these different degrees of benefits, of costs, being scrutinised, you know, by the European reference networks that are relevant to it as well, like Metaburn, but also ERN, Rita, and others. You know, just really think that there's a strong value to doing this all together as Europeans.
Thank you, Steve. And again, to clarify, Johan Prévost from IPOPI was due to be with us, but unfortunately had a last-minute emergency. So thank you again, Steve, for your flexibility. Milan, let me turn to you. I know you've done a landscape analysis of newborn screening across the EU, discrepancies. Tell us a bit about what the facts and figures show.
Thank you, Jennifer. Yeah, so we've been working on a landscape assessment of newborn screening in Europe, I would say over the last 3 years now. As was mentioned earlier, there are significant disparities across Europe in newborn screening, whether this is for the number of diseases that are tested for, around 50 in Italy, to as little as 2 or 3 in some member states, which really isn't quite good enough. There's also significant differences in how organisations are structured, so the level of evidence that's needed, and also the types of diseases that they screen for as well. We're focusing on SMA as a case study today. There's been tremendous progress over the last 2 or 3 years due to advocacy efforts and increased technologies, etc., and the availability of treatments. I think when we started the assessment 3 years ago, only a handful of countries were thinking about screening for SMA, and now we're getting into sort of that 50% mark. We're either looking to conduct pilots or planning to introduce it in the near future, or they've moved to full implementation already.
Thank you, Milan, for that. I am going to just remind everyone again that we are allowed to be interactive here. So if I do see questions from the audience, I will try and give you the floor. If you have something you want to ask at any point, just raise your hand, and I'm sure someone will nudge me and I'll note down and take your comment as we go through the discussion. But Marie-Christine, first, let me come back to you. getting the process of including new or rare diseases into MBS programs, that can be difficult. Can you explain to us a little bit about that?
When we decided to do this at SMA Europe, we thought it would be very easy because we have a treatment. We have a treatment. It's cost effective. We have everything, so we say we will just have to go to the government and say you have to implement newborn screening for SMA. And in fact, it was a nightmare. First of all, it's because we have to apply country by country, but in many countries we have to apply region by region. So we have to fulfill a dossier each time. In many countries, there's not a very clear pathway to decide who we can address to do a newborn screening. So we have to find the right person to give the dossier and to start the dossier. And we have to fill every time the same question to answer to the same thing and to a different way because it's a different questionnaire each time. We decide to find this alliance and the main work we do is to have a white paper collecting all the scientific evidence, all the different techniques, just to support our national entity to be able to deposit the dossier. So it's very interesting. And just I want to say that at the euro level, it can be a very big improvement if at least EMA or something as EMA can give a scientific advice regarding the newborn screening for a disease. If we can have one paper produced at your level saying this disease is recommended or this is why this disease is recommended for screening. Of course, each state can do what we want, but if we only have this document, it will save a lot of time, a lot of money everywhere. And it's more or less what's happened in the US today.
Well, thank you. You've given the answer to my next question, which was going to be what would help, what would make it easier. So, Maurizio, let me turn back to you. And I feel I'm going to ask you an economics question because you did raise it. You talked about that unfortunately it's often seen as a cost. But what is the cost-benefit ratio? How can you best portray that? And we also talked a little bit about the advantages of EU action. Is there an argument to be made there where you can use terms like economy of scale by getting countries to act together?
But when you're thinking about the screening, of course, you are thinking majorly, since you're speaking about rare diseases, about the cost of the therapy that comes after, which is usually very high. But actually you don't calculate the cost of the family, of the working father, mother, working parents, of the cost of hospitalization, of care that the patient without a diagnosis has before having a diagnosis, which is much higher than the therapy itself. So that's why I'm saying that the screening is an investment, because if you make the scale larger, at the end, if you have a society which is not running behind the diagnosis, but is actually anticipating the progression of a lethal disorder, at this point, at the end, the cost is much lower. So this is very roughly. I'm not an economics, so I'm just a physician. So at a certain point, I don't enter very much in this, but I see it, as an example also of other disorders.
And even when the cost is very high for the treatment, sometimes the treatment is already in place. For example, in SMA, you just change the date of the start of the treatment. The government pay a few months ahead the treatment, but they pay the same cost at the end of the treatment. So it's very important to not be afraid about the price of a treatment in many of these diseases, because in any case, the government has to pay the treatment.
Well, I know I'm asking physicians about economics, but I think it's worth hearing your perspective and how you term it.
Sure.
Steve, a similar sort of question to you. I mean, what do you say when you come up against a hard place of pushback on screening for rare? presumably this happens to you all the time. I mean, where do you see your levers for argument?
I think that one of the things that the European reference networks and other groups try to do at European level is simply to build irrefutable data of the benefits. And it's challenging to do that for sure. There's a number of complicated factors at play, but to take something that we think is important that hasn't maybe been mentioned yet is the scientific advancement part of it. So there's a rare disorder called familial hypercholesterolemia, which there have been treatments developed for, and through rolling these out and actually having the experience of treating people with that genetic condition led to scientific advancement that can be used for cholesterol problems in general. So when people say, oh, it only impact a narrow part of society, it's well established that the scientific benefits that are understood can lead to things that impact a much wider group of people as well. I think the sharing of best practice at EU level can certainly support when people give a tough challenge about when advocating for newborn screening, because it's something that evidence and rhetoric are needed in a sense, because part of it is about everybody deserving the fair shot, as Stelios said before, and bringing everything down to euros and cents probably isn't a totally fair way of looking at it. And what we tried to do with the Screen for Rare is to make sure that different people who are affected, implicated, experts such as Maurizio, the patient voice, and try and listen to as many of those arguments and form them into something that is a compelling case in the end. And part of that's economics, part of it's ethics, part of it's science. I think it all has an important part. And for member state governments, they need to understand that being in work, being in education, being able to support your family, have a family, the knock-on effects of this for economic benefit can be a tidal wave, really, as a net contributor rather than a net recipient, which is, from what I've heard of the patient voice over the years, that's you hear that time and again, is people want to be empowered to contribute as they have the potential to do.
Well, we're going to get no disagreement on this panel, I don't think. Milan, let me ask you, you were talking about the discrepancies between different countries and even sometimes different regions, and we've talked about economics. Marie-Christine has mentioned the difficulty in getting new screenings approved, if you like, or added to a list. What are the reasons behind that? I mean, it's been alluded to that maybe there are political reasons, but have you noticed any sort of similarities from regions to region or country to country that you could put your finger and say, well, that seems to be one of the reasons we're seeing less screening there?
Yeah, absolutely. So I think the first part is how diseases get kind of considered for a panel. So it's kind of the application process. So in some countries it could be very difficult even for a patient group or a clinical society to submit an application for consideration of a disease to be included in a panel. So that's definitely one key barrier. The second one centres around the methodologies that are used for evaluation. Sometimes we're looking at it from a disease perspective instead of a testing perspective. Those methodologies don't always show that newborn screening is cost effective, which is a mechanism used in a lot of member states. I think as the evidence is going to come over the next few years, that eventually we will be able to show that, but right now it's kind of in its infancy. And the final one is really around the implementation. So some countries aren't really set up with the testing technologies. They might not have enough labs to carry out testing, and this really can slow or delay implementation for screening.
And within that, do you see any obvious low-hanging solutions, low-hanging fruit?
I think policymaker prioritisation is a big one. We're going to need increased funding to kind of make sure that technologies involved in screening now for MBS, and then in the future as we have increase in personalised medicine and genomics testing and things like that. Those are the kind of two key components, I think.
Well, once again, I turn back to the audience to see have we any questions or anything you'd like to raise with... Yes, sir. Here in the middle. Anyone else before we move on? Okay, if you press your button, please.
Ονομάζομαι Χάρης Βαβουρανάκης, είμαι ορθοπαιδικός χειρουργός και είμαι πρόεδρος του Ινστιτούτου Επιστημονικών Ερευνών του Πανελληνίου Ιατρικού Συλλόγου. Θα ήθελα να ευχαριστήσω τον κύριο Κυμπουρόπουλο για την ευγενική πρόσκληση να συμμετάσχουμε εδώ ως ιατρική κοινότητα της Ελλάδος και εκείνο που θα ήθελα να προσθέσω στη συζήτηση είναι τη μεγάλη σημασία που έχει ο προσυμπτωματικός έλεγχος. Και ως ορθοπαιδικός θα έλεγα ότι κάτι αντίστοιχο έχουμε δει και στην αναπτυξιακή δυσπλασία του ισχύου, όπου όταν σε κάποιες χώρες μπήκε ο προσυμπτωματικός έλεγχος με την έννοια του υπερήχου και κυρίως στην Αυστρία που ξεκίνησε εκεί από τον καθηγητή Γκραφ, είδαμε ότι μέσα σε ένα πολύ μικρό χρονικό διάστημα μειώθηκε, όπως πολύ σωστά ανέφερε ο καθηγητής ο κύριος Σκάρπα, μειώθηκε πάρα πολύ το κόστος στις επόμενες γενναίες, μειώθηκαν οι επεμβάσεις της αναθεώρησης του ισχύου και τις ολικές αρθροπλαστικές και φυσικά το κοινωνικό κόστος της οικογένειας οι οποίοι είχαν τα παιδιά τα οποία είχαν προβλήματα και δεν μπορούσαν να κινηθούν. Αυτό είναι το πρώτο στοιχείο που θα πρέπει να μπει κυρίως στις νευρολογικές κλινικές, να ευαισθητοποιηθούν οι παιδίατροι για να μπορέσουν να έχουμε αυτό το αποτέλεσμα. Και το πολύ σημαντικό στοιχείο που αναπτύσσεται εδώ και αισθάνομαι περήφανος ως Έλληνας που το ξεκινάει ο κ. Κυμπουρόπουλος, είναι το ότι θα πρέπει στην υγεία να εφαρμοστεί η ευρωπαϊκή πολιτική με βάση τα σπάνια νοσήματα και ίσως με το προσυμπτωματικό έλεγχο να αποδείξουμε ότι μπορεί να μην είναι και τόσο σπάνια για να μην έχουμε τις χαμένες διαγνώσεις στη διαδρομή αυτή. Σας ευχαριστώ.
Well, thank you very much. I think that's a point that has been echoed several times from our speakers, which brings us to the end of this panel. We're going to have our final panel coming up next, but please show your appreciation for our speakers. And so once again we will have the quick change of the panellists. Our final panel is going to be on those key issues related to the revision of the EU pharmaceutical framework. I am sure references will be made to leaks and to the fact that we don't have final text, but we will endeavour to try and drill down a bit.
Hello.
Hi. Okay, well, we're finally at the point where we are going to talk about the politics and the policies. We've heard, first of all, we've looked at more of a personal angle, living with the disease, the patient's perspective. We've looked at screening as just a really strong example of where things can make a difference if there's joined up thinking. And now we are going to talk about the revision of the EU pharmaceutical framework. So, joining me, we're delighted to have from the Renew Group here in the European Parliament, Susana Solis Perez. Thank you very much. Also from the European Commission's DG Sante, Fabio Datri. Thank you very much, Fabio. Chair of the Greek Patients Association is Nikos Dedes, who is right next to me. And, of course, representing FPA, the Director General, Natalie Moll. So thank you all very much. Let me start, Susana, with this end. What are the key issues still to be addressed in the legislation? Where do you see it can be improved? Where are the loopholes? What's already good?
So thank you, Jennifer. First of all, let me thank Stelios for inviting me to participate here. It is a pleasure. For me as policymaker, I think there is incredible value in listening to patients and knowing their exhausting process until they get diagnosed and have access to treatment. I have to say, the more I participate in this kind of events, the more convinced I am that we are at a unique moment here in the Parliament. And I want to ask you to keep this momentum beyond the Rare Diseases Week, because we must seize this opportunity. And when I think we have now on the table the reform on the pharma industry, also the creation of the European Health Data Space, which is very important in order to have all this data available across Europe. And on top of that, and hearing all these testimonials today, I think the last step should be the commitment to have an action plan for rare diseases. I will try to have it under the Spanish presidency, because it will be the only way to have this holistic approach and to take care of people suffering from rare diseases. Responding to your question, I think, as we mentioned before, we need to improve affordability and access and availability for patients. What we cannot afford is to have this two-speed Europe of health. It is clear that we don't have equitable access to therapies. I come from Spain. We were talking about the screening, but even among, not only the differences among member states, but even in Spain, depending on which region you live, you have screening for 6 illnesses or 40. So this is not fair for European patients, and I think the pharma legislation will be key for us. You mentioned before we need to faster the authorization process, and we need to refocus investment in areas addressing unmet medical needs. So the question here that we will need to discuss is how we can find the balance. It will be the big discussion in the Parliament, but for me it's important that where innovation happens, ensure innovation happens in Europe, because it means that clinical trials will happen in Europe, patients with rare diseases will benefit from them. So we need to discuss how ensure that we enhance innovation and we work together in order to get this.
Well, thank you very much. Indeed, you mentioned the Spanish presidency, so representing, if you like, that move forward. Let me turn, Fabio, to you to ask what are the key issues to be addressed in the legislation. I'm sure we all know most of them, but it wouldn't hurt to have a recap from your perspective.
Thank you very much. But as everybody has said, the field of rare disease can only be approached in an holistic way. We have to look at several perspectives and several actions. So the legislation will not be the solution for everything. The legislation will help, will be a piece in this framework, but for sure will not solve all the problems. So we really need to have this holistic view. What the legislation will try to do is really to find this balance between innovation. We want innovation in Europe, and access and affordability. We want to still, what we are proposing in the legislation, what we are thinking to propose in the legislation is a system that rewards innovation, and the reward of innovation is still one of the higher in the world. It's much higher even what we will propose than what we will have in the US. But at the same time, to try to have medicine available in all member states, accessible in all member states, or in the majority of member states, is not always possible, because sometimes we are speaking of small populations. Sometimes there are no patients in some member states. Or if we speak of, for example, advanced therapy, there are only few centers in Europe that can administer a specific medicine. So, I mean, we speak of all member states, but with a certain logic. So if it's only a center is a few member states, only there is necessary that the medicine goes. The other things is important in the revision is the streamlining of the procedure, the simplification, the avoiding duplication. We have seen in the COVID, we have heard before speaking about the experience in COVID, Europe can authorize product much faster than it's doing today. This we avoid by avoiding duplication, by streamlining the procedure, and this also will help Europe to become competitive. Another thing that I wanted to say, we hear a lot, we have heard a lot about clinical trials, and we want clinical trials in Europe. What we have seen is that really a decrease in clinical trial in the last 10, 20 years in Europe. So it's going down, especially in innovation. I'm not sure that incentives is the reply to having clinical trials in Europe. What determines clinical trial are various things. I mean, we have now a new clinical trial regulation that is has become fully applicable 5 days ago, 7, 8 days ago, finally. And this will facilitate an authorization of clinical trial all over Europe with one assessment. But then we have also to look at national level, at local level. There are very different local level. So we need a clinical trial center, and this is the responsibility also of member states of supporting the local development. We need expertise. Europe can do something, but is also to support expertise in the formation. So the training of doctors, the training of patients, and patient needs to have a role in the clinical trials, a leading role in the clinical trials. So the regulation can do something, but not everything. And I would say this, what MEP mentioned, Susanna mentioned, is this balance that we have to find between access and affordability and rewarding innovation, keeping in mind that we will continue to keep the rewards at a very high level for rare disease, much higher than in other jurisdictions. And I've heard, I mean, there has been the leak. I will not comment directly on the leak, but we are not touching intellectual property. We are not touching patent. We are not touching supplementary protection certificate. These are the tools that reward very innovative products. I will not enter into detail because they are very technical issues, but we are not killing innovation. So let's keep this in mind. Thank you very much.
Thank you. Nikos, let me turn to you and get your perspective. How will access and availability be enhanced? Will it be enhanced? And perhaps you can, if you wish, to take the time to reflect on some of the things you've heard so far.
Thank you, Jennifer. And I would like first, of course, to thank Stelios for the kind invitation. We know each other for many, many years, and he's a beacon, an example of what people with chronic conditions can achieve, and we're very proud for you. And also, we count very much on the influence that you can exert together with the colleagues. I would like to start with something that struck me as a very interesting point that Peter Liese raised about how the subsidiarity in the case of rare diseases actually forces all of us to deal with rare diseases at the level of Europe. And I think that this can be very well highlighted by a survey that has been commissioned by FPA and conducted by IQVIA, which wanted to see the access of medicines across Europe for medicines that were approved between 2017 and 2020, therefore sufficient time to reach all countries. And in the case of the rare diseases, rare conditions, there were 57 such medicines approved during that period. Out of those 57, actually, I'm glad to live in a country which is 8th or 9th in accessing those drugs, 32 of those 57 drugs. In the country from where Commissioner Kyriakidis comes, only 12 are available there. So this highlights the problem that we face in terms of access to these particular drugs. And obviously one thing that I also would like to say is that I feel that rare conditions and rare diseases is a misnomer. I come from the HIV field. I'm a person living with HIV. In Greece, around 15,000 people live with HIV. I can assure you we have something like 35 to 40 drugs. It has been turned into one pill once a day. I expect to live to 90. And we have 600,000 people living with rare conditions. And they do not have anything near that. Therefore, this is something that, but as Fabio said, we have to deal with this holistically. It won't be solved exclusively from the legislation. Very fast, from what one of those who have not had the chance to read the leaked document, but it's clear that this balance between attractive incentives, which we obviously need in this field, and affordable access that would enable all countries in Europe to have, requires that we see, first of all, what is to define an R&D model. And I'm, of course, speaking from the fantastic work of Eurordis and the team of Jan Le Cam, that it's centered to unmet medical needs. And what we need is a very clear definition for unmet medical needs or high unmet medical needs, and this should not happen through a legislative text. So obviously you should describe the process and the committees that would be able to do that. The other, of course, it is absolutely clear that we need to see all these variable incentives, and therefore the gradation is important, and that is where we need to be involved. Obviously, we need also to see innovation in how we price or reimburse medicines. So procurement or anything that we can strike an understanding with FPA and the companies. This is something that we must ensure. Also coming as a former board member of the European Medicines Agency, representing patients, like Jan has done as well, I think that there is a role for a European agency to improve very much the speed and the things that the agency can do. Amongst other things, obviously, make sure that scientific advice is mandatory and given to, particularly to companies that want to invest in this. So I'll stop here and come back later.
Thank you. Natalie, let me turn to you then. We've covered a lot of ground already so far on this panel. Perhaps you can pick up on some of the key points that have struck out to you.
Thank you very much. Yeah, with pleasure. I was trying to, as I was listening to everybody's intervention, it's been a long day of super interesting interventions. How can I say things in a way that people can still pick up at the end of the day and that make a difference? And maybe I would start with saying we need to prioritize. So we are in a moment in Europe very different from when we started the pharma strategy in 2019. We've had COVID and we have a war. Our healthcare systems are struggling. So we have an emergency in that sense. We have to be logical in how we prioritize action. And on the other side, we have an emergency of patients who are waiting and don't have time. And that's always on my mind. And when I'm in the rare disease community, it's even more on my mind. It's even scary. And what the mother of the SMA patient said so well is you never know when you might get a rare disease or when your children might get a rare disease. And I have 3+1, so there's lots of children. So we need to prioritize. And I think this is very, very important because, as Fabio said, we're not going to get solutions to everything through a revision of legislation, which will take 3, 4, 5 years. That's a long time. Okay, so what do we want to get out of this legislation? What kind of pharma industry do we want, as Olympio said at the beginning, through this pharma legislation? It's a question that Europe has to ask itself very seriously. What kind of pharma legislation do we want? Because when we look at what's been proposed, I have to disagree with you, Fabio. I don't think Europe has a higher IP. We've checked. In the US, biologics have 12 years of protection. So we do not have a higher IP in Europe. And the proposals are to reduce the IP. They are. Maybe not all IP, but they are. And the message it sends is this is not, the framework is not for the innovative industry. The way it stands today, it might change. But that's what's concerning, right? But that's the legislation. As you said, you can't fix everything through the legislation. What can you do through the legislation? You can improve the regulatory framework, and that's so urgent. So if I were to prioritize, I would say, let's do this. Let's make sure the regulatory framework is up to date. It can welcome all the latest innovations because, for example, for clinical trials, you were talking about that just now. We have the CTIS, but the IVDR is not working. So we actually can't do clinical trials for combination products or personalized medicines today, and many of those are OMPs. So we need to prioritize what we're doing here. And for me, the regulatory framework is important. AMR would be a great place where we could put new incentives because it's a market failure, it doesn't work. And then we need to take responsibilities, all of us, for other stuff. And we need to take responsibilities for access. You mentioned that. And we did, and we have. We've put in place our commitment. We've taken action as of last April. We've committed to file in all member states and to measure that and to publish the result of that regularly. The first report will come out in April. So we're committed on improving access. We're also committed on trying to get over the scientific hurdles. And this was another thing I wanted to say. When we talk about the 95% of rare diseases that don't have a treatment, those affect 10% of patients. What the industry did first was look at 90% of patients. It's important. We prioritized meeting the needs of 90% of patients. That kind of is logical, right? That's a huge, massive unmet medical need. The 95%, 10% of patients is important, even 0% of, it's still a patient. But those are the most difficult scientific challenges. So that's what's next. And with the moonshot that Olympios mentioned at the beginning, we're joining forces with Eurodis and research centers and other associations to try and overcome those obstacles, because those are the toughest, the most difficult. So prioritize the science. Prioritize which patients you start with, the biggest ones, and then you move to the most complicated. Everybody takes their responsibility on the areas they can, so we'll do access. But don't try and put everything into a piece of legislation that's going to take a number of years, because what's going to happen, I know, I've been here for 27 years, we don't have the time to try to fix everything through a regulation. We really need to prioritize what we can and put the monkeys on the shoulders of the people who need to fix the other things, rather than try and fix everything in a piece of legislation, which I'm really worried is just going to send us through loops and loops of consultation. We won't have the new regulatory framework. We won't have support for incentives. We've lost 25% of R&D investment in innovative pharma over the last 20 years in Europe. It's gone elsewhere. It's going like this. Either we stop it and reverse the trend, or we will be left with a very different state than we were in when we were looking for a vaccine. So I'm worried about our resilience. When I hear about, we want a resilient Europe, we want a Europe, if I look at the Council conclusions or the draft Council conclusions of the next 2 days, it's all about resilient Europe and competitive, and we're there for SMEs. These texts don't look like that. So going back to Olympios, we need to decide what kind of pharma industry we want in Europe, and based on that, prioritize.
I think you'll find strategic autonomy is another one of those buzzwords that's coming up quite a lot. Let me turn, Fabio, let me come back to you to sort of comment on what you're hearing. I mean, a legislation cannot address market failures. Is that even its role? I mean, we shouldn't expect it, or should we? Perhaps you can give us your perspective.
Well, I think market failure, for sure, the orphan legislation has helped in addressing the market failure. I think we all agree on this, that before the orphan legislation, before 2000, there was almost nothing in Europe. So the legislation has helped to address the market failure in these specific areas of orphans. On rare disease, where there was nothing. Now we have 230 medicines that are authorized for rare diseases. I agree with Nathalie. Industry has addressed the biggest need, so the biggest patient population, and for some diseases, the genetic diseases, is very difficult. The science is not there, so we cannot dream that even if we go with whatever number of years of incentives, we will not solve the problem. I disagree with you that what we are proposing is not competitive. We will push away innovation. I think we have to create a balance. We can have industry, we can push in, give incentives as much as we want, but this results in product where the price will be impossible, there will be no entry of generics until X years, and the health system will not afford this. So we have to find this fine-tune where we want to position ourselves. And I will not comment today on the number of years, on the details, but I think we have all to come close and not to start and say we cannot modulate, and we can only modulate upward. there is a thin line where we can modulate. And on access, yes, I think what FPA is doing, and your creating this register and the engagement to launch within 2 years, I think, is a very good step. So, but each actor has to do something. This is a first step. I think the legislation can also help to enhance and can also push, is a way also to push member states to address and to work fast. We are not saying that is an obligation. It's a reward. You launch in the member state where there is the need, and you get a reward. So we are not doing something. So I think each actor has to do something. And yes, it will take time. The legislation we are discussing now will apply probably in 3-5 years. But we need to do something now. We have to reform. I mean, there are things that absolutely we need to do. The authorization, the pathway of authorization, we cannot go like it is today. We are independently from the incentives and the rewards. I think if we all look at the time that it takes in Europe for authorizing a product is higher than what happens in other jurisdictions. So, and there we are not competitive. Patients are not getting timely this medicine, and so we need to act. Even if this will happen in 5 years' time, 3 years' time, we have to act. So I think it's a common responsibility. Each of us has to do a small bit, and all together we will manage to have a regulatory framework that is future-proof, that will give certainties to everyone, is reward innovation, but at the same time will push to have an healthcare system that are sustainable, and patients have to more access. Thank you.
Nikos, you want to jump in?
Yes, thank you. Well, Fabio, from the patients and citizens side, I want to ask this question, because you are right, we need all the framework. But how about implementing the Transparency Directive, which hardly is in place in so many countries? Which would have helped, the initiation and the reimbursement and all of these things. Yeah.
I think what we are proposing will also push member states to implement the Transparency Directive. What it happens now is that the Transparency Directive gives a certain timing for member states to start and finish the pricing and reimbursement. What they do is that they don't start. They start in
So you mean legally everything is okay?
Legally is okay. I mean, legally, let's remember also that not in all member states the companies goes with a price that is not all member states. So let's remember this. But I think that is a push. What we are going to propose is a push also to member states really to start, and the Transparency Directive, yes, need to be implemented.
Thank you. Susanna, let me come back. There's been a fair bit of discussion. Things that I would like you to reflect on, give me your perspective to jump in on is, I mean, this future-proofed regulatory framework. What can the Parliament do? Time is of the essence, as Natalie's saying. What again? Where does this legislative body fall in encouraging that to speed up? And we've heard again, we're taking it as a given this balance between innovation and affordability. I mean, is it really a zero-sum game, or is that a misnomer? That's a lot of questions in one, so feel free to take them in whatever order you like.
There is a lot of questions, and I don't have the answer because, as you can see, the discussion will take a lot of time here in the Parliament, but I suppose in the Council. And we need to make sure that Europe is competitive. This is important for me now that we are talking about strategic autonomy. For sure, the biopharmaceutical sector is a strategy for Europe. We have seen this during the COVID pandemic. Now we have to make sure that with inflation that we have in Europe, with the energy crisis, the prices and raw materials, we are competitive. And this is something that we need to find the balance. We will discuss it. We will discuss it in the long term. I think there are very positive things in the pharma legislation when we look at this speeding the process for approvals, when we look at we tackle AMR, when we tackle the shortages we have now in Europe. Those are very positive points, but the elephant in the room is what we do with incentives, if we look at them as in a positive way, or if we look at them leaving the countries to opt out for which treatments are available for patients or no. So that will be the big discussion, but I think we need to discuss here all together. For me, ATMPs are critical for rare diseases, and we have to make sure we have this agile framework and that we have these clinical trials here in Europe. And my cooperation to cooperate and to work with you.
Indeed, and as Natalie pointed out, we are living in a different era. I mean, the COVID pandemic did put a new slant on things. We look at things differently in terms of what is achievable. So that is possibly giving policymakers a push. Is that something that stays top of your mind to reach for what's potentially possible?
I think so. I think after the COVID pandemic, after the the war in Ukraine, we see things, everything could be feasible. We have achieved things that we have never expected, like this. We should cooperate, and I think this is all the stakeholders should be involved. And this is the main point for me, for the political groups, because when we talk about patients, who don't want access for patients as the priority, but we need to find a balance, and we should discuss this.
Yeah, and you have a question from the floor. Is there anyone else who wants to raise their hands? Okay, I see 1, 2, 3, 4. Okay,
you see,
so
at the end of the meeting, everybody wants to take the floor. That's good. I don't know if it's more a comment really than a question. Is that the future proof is really the thing, because as you're both saying, it takes 3 to 5 years to implement, and then it will stay there for 15 to 20 years. So we're talking about 2040. If we look at other legislations in that area, that's what we're talking about. Are we really future-proof? This is where really I have doubts. I think what we have seen from the leaks goes really in the right direction. Does it go far enough? I'm not sure. What I read is still written under the lenses of the payers and affordability. So we're trying to solve something into the legislation that it cannot solve there. It has to be plugged into additional policies. And second, it's a lack of faith in Europe still. That's how I see it. There is elements there. But for instance, we've been proposing that there is a plus 1 year market exclusivity if the product comes first in Europe. I'd like that to be more considered. Why not? That would be a message. That would be a message, come to Europe first. And that means more investment in clinical trials in Europe. Because when we say, and I don't remember the figures, but we can check on that. When we say that there were 8 medicinal orphan drugs before the legislation expired, that now there is more than 230. Okay, true. But how many of them have been approved first in Europe? That's what we need to look at. We are a following market today, and more. And that means that we are not sufficiently pushing that. The second is that we need to take more responsibility, and that's particularly through the EMA, but not only, to team up to address the challenges of development of rare diseases. And that's protocol assistance scientific advice. And I think the mindset is there in the text, but it doesn't go far enough in terms of making compulsory protocol assistance, having development plan for orphan drugs to increase the success rate, and to be ready for the science of tomorrow, for the design of trial of tomorrow, and also for the development of medicines for the rarest diseases where our system will not work. The 1 in a million, we have difficulties to work. And my last comment is that we need also a system that plugs regulation and policy so that there is real access. And I see nothing today in what we have to address the issue of the gene and cell therapies for the very rare diseases which are delivered in only few centers in Europe. And that's not going to be solved by the legislation and not by additional market exclusivity if introduced in every national market. It would be solved if you have coordination with the policy of European First Network and with the payers and reimbursement authorities.
Thank you, Jan. I'm going to take a couple together because I'm conscious of time. So yes, your comment or question.
Yes, thank you. I am Caroline Roata. I am the president of a rare disease association called ABP Wilson France. I just wanted to point the fact that the role of patient has evolved too during the last 20 years, and I think it is very important to know that we are better organized in associations, in networks that are getting stronger thanks to ERNs, thanks to URDs, and that we are more and more capable to negotiate and collaborate in the local, with our local governments, but we also interact with pharma industry. So we are ready to have this new legislation, even if this negotiation can be complex, can be there will be some tension, some time, but I think it is important to point that we are not only patients who are waiting for treatment, we are patient experts who have something to say, and we are. I think it is important to see how we are talking about not only translational research, but also citizen research, because we are citizens and we have something to say. So I wanted to point that, because it is difficult for me to only hear how you talk about patients like some kind of object of research. I understand, but we are ready. Thank you.
Okay, absolutely. Fabio, I will let you react to those couple of comments first.
Yeah, no, I mean, just on the future-proof. Yes, future-proof, I think that the regulation will be what our proposal will be future-proof. We can discuss on the details. I will come then that plus 1 year for first in Europe. But for example, let's take an example that the definition of high unmet need or unmet medical need. What we have, I know that everybody reads this in a different way, but what we have now is just a framework. We don't have strict criteria. What will define which diseases will be classified under one or the other will be done with the collaboration of all interested parties, including patients, so the patient will have an active role. And this will make also the legislation leaving out a little bit of all technical details and having them a little bit more flexible, will allow to have some flexibility. We are also introducing exceptional circumstances, for example, for the authorization of medicine. This can be something that will be interesting for the rarest diseases, where the data collected in clinical trial needs to be conducted in different ways. So let's not look only the orphan part, but let's look overall everywhere. On the +1 for the first in Europe, as I said, I'm not 100% sure that having more incentives can automatically bring clinical trial in Europe. Clinical trial can be conducted elsewhere and then filed in Europe. Let's think about what attracts companies to do clinical trials in Europe. Is it really 1 year of incentives because they have to file an application, or is more having an agile system for the authorization that works for clinical trials? And I think what you said, I mean, the in vitro diagnostic, the CTs and the various, is very important that we have an IT system and legislation that speak between themselves. So a framework for clinical trial that is fit for purpose. And yeah, it's becoming, but it's not fully there. And then we need infrastructure. Eventually, we'll be open to negotiation.
Natalie, you wanted to add something quickly.
Sure. I also first wanted to, perhaps I explained myself badly before. I didn't mean we don't want to do the legislation. We do. I was there when we did the first one, so I remember in the end of the 90s. We really do, but we want to, in this legislation, do what's going to work through the legislation and not wait for it to fix access, to fix scientific difficulties and other things. So what I meant was, on access, we need to make progress now, and this is why industry took those steps. And one of the steps is also around price, but that's something we need to work on together. The famous solidarity that I heard before, which was really that we don't need empathy, we need solidarity. This is really, we're proposing that it will mean that the countries that have more capacities will help countries that have less capacity in our model. But then we have to discuss how to put that in place, because today it's not feasible. So I'm just saying, in the legislation, let's do what is absolutely necessary to do in legislation now, so make it future-proof, etc. All of us take our responsibilities in other areas like access, scientific progress, etc. And let's be fast. And I didn't mean at all let's not go through the different steps. Then I also want to talk about biosimilars and generics. If there's an area where there are very few, if none, biosimilars and generics, it's this one. Right? So biosimilars and generics don't come in the orphan space. It's not because you're going to reduce the incentives in this area that you're going to have more biosimilars and generics. It's the most complicated and difficult and tiniest population you would ever have. So I think we need to make sure that we, tailor the proposals to areas where it makes sense, and not just use blanket ideas everywhere, because this is an area that is so important. And yes, incentives really do matter. But it's true that they're not alone, right? So you need everything. You need the clinical trial. Also, for advanced therapy medicinal products, you have the hospital exemption to such a level, and I also worked on that regulation, by the way, that everything is going to the US, even from companies that are purely European. They open ATMP centers in California. So it tells you something. But this all means that we need to make sure that the ambition that we have with the revision is realistic, so that we get it done in the time that it will take, and that's very important. But in the meantime, we work with patient experts, we work with member states, we work with payers, we work with all the different elements that are needed to solve the other areas, because it's a continuum, right? It goes from research to access, and nothing on its own is worthy unless the next thing follows. So I just wanted to clarify that.
Thank you. Can I see just how many more people wanted to make a comment or a question? Show of hands. So just 3. Okay. If I could ask you to be succinct, because we are already over time. So, grey jacket first, and then.
Thank you. My name.
Microphone.
Oops. Thank you. My name is Juliana Dumitriou, and I represent rare disease patients. I'm a founder of a rare disease association because my child, as previously said, it can happen to anyone. My child has a rare disease. He's 8 years old. 1 year ago, I discovered the terrible diagnosis. So I founded this association, and I am the Coffin-Lorry Syndrome Association. This is the disease of my son. And I am here at Auror's invitation for the Rare Disease Week. I have been very happy to see so much attention and so much legislative proposals that are undergoing. And regarding the discussions from this panel, I just like to make a few remarks on behalf of the community of the patients. And I want to say that it has been mentioned that the new medicines can be a burden for the national systems. I noted that down. And it has been said also prior panel that the cost of not having a diagnosis is also high. I would like to add that the cost of living with the rare disease, either that I have it or my son has it, is also extremely high, not only for the family, but also for the national system and for the European system when I apply to European care. Thus, with the patient community, I think that I think everybody thinks like that. Think that stimulating the research and the innovation in disease categories, for example, can be highly profitable. And I will give you the example that I know personally better, and that is the intellectual disabilities. I also joined the ERN ITACA, which is the European Network Reference for the Intellectual Disability and Congenital Malformations and Autism. And yes, one intellectual disability, Coffin-Lorry syndrome, is rare, is very rare. But if you take together all the intellectual disability, they represent a high burden for the national costs. However, if you stimulate the research in the mechanism, in the neurological mechanism that triggers a category of diseases, then I think suddenly it becomes profitable. and it becomes profitable for everybody, for the national system, for the pharmaceutical companies, for the patients, for the families, and in the end, I think for the Europe, because we are here to sustain the rights of the people and of the nations and all of the companies that are in Europe.
Thank you. Okay, we'll take a comment here and then over here.
I'm Kasper Rucinski, founder of Rare Disease Association in Poland, SMA Foundation Poland, also member of SMA Europe and of the steering committee of the European Alliance for Newborn Screening for SMA. I'm also a father of a child with a daughter with a spinal muscular atrophy. I'll try to be brief, perhaps slightly controversial. The discussion about incentives, I think, is slightly misplaced because when we see how rare disease drugs are developed, what the proposed regulation, okay, I haven't read it, I haven't seen the leak, but from my understanding is it does not incentivize the actual entities that develop rare disease drugs. The development of treatments takes place in small biotechs, in non-profit organizations and charities. They are the ones who develop, who really do the basic pre-clinical development and early clinical development. The incentives linked with bringing a product to the market are offered to big pharmaceuticals to large pharmaceutical companies who just fish for interesting leads and see whether that will make a business case, license it, put some extra money, of course, investment and risk, and then bring it to the market. The original developer gets a small percentage of the total revenue, and I know it. I will not quote the numbers or names, but I think we know. And so, but the major risk, who is taking the risk? The biotechs are taking the risk because they're investing in products and they will not be in molecules that they don't know whether there will be buyers for them. So this regulation, to me, it doesn't go far enough to increase the number of rare disease treatments that we have. Remember, we have 6,000 rare diseases, identified rare diseases. Imagine even if to have one treatment for each disease, we have to have 6,000 new products. So offering, say, big pharmaceutical companies longer marketing exclusivity, in my opinion, will not bring us closer to that goal. We need to really look into mechanisms to offset the risk of developing new molecules. That's all right.
Thank you. I'm just very conscious of time. I know we've even gone over the 10 minutes extra that we were allowed. So I'll give a final word to the floor over here and then a very brief wrap-up from each of our panellists. So, sir.
Yes, Thomas Kangatona, working for AIM, International Association of Mutual Benefit Societies. My comments will echo a bit, to some extent, those of the previous speaker. I think that the way we frame the discussion around building from a framework for a disease puts us a bit in, let's say, in a face-to-face between, let's say, healthcare systems or legislation and towards, and let's say, commercial organizations. While actually there's actually many more things taking place. When we talk about SMA, this disease, it was developed thanks to first donation to charity, developed via charity. Then these licenses were then bought out and then came to a company that at the end actually brought the product to the market. But the very first, let's say, endeavor was made via donation to charity. And sometimes actually we don't see, let's say, the accountability aspect when you have, let's say, a product that has been developed with, let's say, yes, donations, and that then becomes the highest and the most expensive medicine that ever exists. You actually don't see where is, let's say, the accountability on the side of the commercial developer. And it's something that we would like to see actually in the legislation, that there's also more power to then counteract and also ask for this accountability to the people who actually have asked for such a high price. I wasn't meant to speak today, but I want to make this point, so I hope it's clear. Thank you.
Well, thank you very much as well for making that point. We've gathered together a lot of different thoughts here in the room, and I know there's strong feeling, strong emotion, but I think a general feeling of working together with only varying ideas on how to get to where we want to go. I think the aim and the destination is probably the same for all of us. I will give just a 2 or 3 word look into your crystal ball. What do you want to happen in the next number of months? How soon do you think we're going to see some change? Very quickly, Susanna.
Very quickly, because I want to thank you for your contributions. I think involve patients and reinforce the ERM are out of questions. And for me, access to treatment is how to find access to treatment is the main point, and we need to discuss how to do it, if this is the right model or no. The status quo, for me, is not an option after hearing all of you, and I took part in many events like this. And I insist we should have an action plan for rare diseases where we can have the whole the holistic approach from the diagnosis to the treatment to the care. So we will fight for it. Thank you very much.
Thank you, Susanna. Nikos, a final, very 30 seconds, quick wrap-up.
Well, I think after COVID and with all this attention that all citizens of Europe have given, I think it's a great opportunity for the Parliament and for all stakeholders to engage in this discussion that is going to take place in the coming months. So I've heard things that also opened my eyes in terms of things that I believe should be more clear or added in the legislation. So I think that all of us collectively have a lot of work to do. Thank you for all the work that has happened. There was a lot of consultation, but now we have a very specific text in front of us, and it has to be future-proof. So a lot of intensive work coming up.
Thank you. Fabio, not to open any new cans of worms at this point, but do you want to give us a sneak peek on timings?
Timings. I mean, I think, like my head of cabinet said, the adoption is planned for the next month, also for March. The text is under internal consultation, so I mean, who has seen can still change a little bit, and then we count on our colleagues in the Parliament and then in the Member State to discuss. And I think what we need really is, apart from the co-legislators, also to have the discussion with all the members of the society. And now we have focused, just one very quick word, we have focused very much on incentives. Access is very important, but we have focused on incentives. And we have heard that there are other issues that are very important. This model on how medicine for rare disease are developed, and the funding, how much funding is given to research, and how this can be reflected, and the transparency. So there are a lot of other things, and legislation, I conclude, is not everything.
Thank you. And Natalie, very briefly, any words to those legislators in the coming months? Encouragement.
First of all, I just wanted to say, wow, because all of you stayed. And it's, no, but seriously, we all have families and children and all sorts of other things, and you all stayed. And this is a message to how important this topic is for the next 20 years, right? Because what we're doing today is deciding legislation that will enable or not enable patients in Europe to have the latest medicines in the rare diseases. So that's all I want to say. Can we keep this momentum going, like you said, after Rare Disease Week, please? Thank you.
Well, thank you very much. And I'm just now going to invite Stelios to give us a few closing words. If you can, a tough order to sum up everything that's been heard. And I know, Stelios, you outlined a lot of your views at the beginning, so this is your opportunity to close out today's event.
I don't know how easy it is to sum up all this fruitful discussion the passing 2 hours, but I think to say some words regarding the preparation of this very timely event. If you have seen the composition of the panel except for specialists, experts, industry, commission. When we prepared the event, I want to have patients in the center of this process, because I think that their role is very vivid and very important for what we are going to happen during the upcoming months. And I want to have something which is very important for me. I would like to strike out the word unmet when we talk about needs. We cannot have in the same sentence these two little words. So I think that that it was not possible to finalize the discussion today, but what Fabio said, we opened again this ongoing process. And I would like to leave this room today having in mind the word from the mother who said, profit. This is what we are going to devise. It's a profit as a general idea, a holistic idea, not only an economical profit. We're talking about profit for society, for people, for the future. So we need to keep this word in mind, profit, and to implement it in any way of living. And I totally agree that we need this in-depth revision, which is coming, and is happening once every 20 years. And I feel very, very lucky that I can contribute to this revision and to this momentum. This revision will help our children's life in the upcoming years, and will give to rare diseases community more opportunities to have access in innovative medicines. Today, we talked about the social aspects of living with a rare disease and how the right treatment could contribute in patients' quality of life. Also, the data for newborn screening showed us clearly that we need to push further as politicians to have common rules and efforts if we want to support future generations. Of course, based on other cases, we are aware of the cost effectiveness to have newborn screening, but for me, is a clear opportunity for every child to have a personalized treatment. Also, we agree today that this upcoming revision can provide the right opportunity for an EU action plan for rare diseases. Achieving that would be a tremendous victory for the rare disease patients. And I want to welcome and thank all of you for being here with us. Και θα τελειώσω μιλώντας στα αγγλικά. Στα αγγλικά, συγγνώμη. Ήταν πολύ σημαντικό που ήσασταν όλοι εδώ σήμερα, οι ειδικοί, η βιομηχανία, οι ασθενείς που έρχονται από την κοινωνία των σπάνιων παθήσεων, που τελικά δεν είμαστε τόσο σπάνιοι, και δώσατε την ευκαιρία να μιλήσουμε για ένα τόσο σημαντικό ζήτημα, να κάνουμε ένα ταξίδι, να ακούσουμε τις φωνές των γονέων, των επιστημόνων, των ανθρώπων οι οποίοι εμπλέκονται σε αυτό το σημαντικό γεγονός που, όπως είπε και ο κύριος Δέδες, μπορεί πλέον οι ασθενείς που διαβιούν με HIV να έχουν ένα χάπι την ημέρα και να ζουν καλά, να ζουν μέχρι τα 90, αλλά για εμάς που είμαστε πολλοί άνθρωποι, ακόμα δεν έχει δοθεί η κατάλληλη προσοχή. Και θέλω να ευχαριστήσω από τα βάθη της καρδιάς μου την FPA, τον SMA Europe, την Ένωση Ελλήνων Ασθενών, τη Screen for Air, καθώς επίσης και τον συντονιστή μου από τη μεριά του Ευρωπαϊκού Λαϊκού Κόμματος, τον Πίτερ Λίζε, από την Επιτροπή Περιβάλλοντος, την συνάδελφό μου, την Σουζάνα Σόλις Πέρεθ, για την παρουσία της εδώ πέρα και για την τα λόγια που είπε και την σημαντική προσφορά της σε αυτό εδώ το πάνελ, καθώς και τον Γιώργο Ρωσίδη και προσωπικά την κυρία Κυριακίδου για την παρουσία τους εδώ πέρα. Τέλος, θα πω ένα μπράβο στη Γιουρόντις που είναι αρρωγός σε όλα αυτά που συζητάμε σήμερα και είναι στο πλευρό όλα αυτά τα χρόνια στο πλευρό των ασθενών που πάσχουν από κάποια σπάνια ασθένεια. Σας ευχαριστώ πραγματικά από τα βάθη της καρδιάς μου για αυτό το σημερινό event.
Thank you very much indeed, Stelios, for hosting, and also thank you to the interpreters, without whom I would not have understood most of that.